Hello, my name is Piotr Sobiestrzyk, and I'm an attending physician in the cardiovascular division, vascular medicine section, and cardiac catheterization laboratory at the Brigham and Women's Hospital. It is my task today to discuss the current management and diagnosis of peripheral artery disease. I have no conflicts to disclose relating this presentation. Let's start with a definition of peripheral artery disease, which is best described as a presence of a stenosis or occlusion in the aorta or in the arteries of the limbs. Most commonly, we are talking about the lower extremities, but some of the points brought up today also are relevant to the upper extremities as well. It is usually caused by atherosclerosis, though vasculitis and other less common etiologies should be kept in mind. Of course, because atherosclerosis is a systemic disease, peripheral artery disease is associated with an increased risk of cardiovascular and cerebrovascular events, including death, myocardial infarction, and stroke. And this is because there's a significant overlap between peripheral artery disease, coronary artery disease, and cerebrovascular disease, as you can see on this Venn diagram. And this has been recognized for a long time and has led to the acceptance of common medical therapies for all three of these vascular beds. When it comes to diagnosis and particularly management of peripheral artery disease, it is important to think about what clinical syndromes are caused by involvement of the particular vascular bed in question. And so when it comes to peripheral artery disease of the lower extremities, we encounter patients with intermittent claudication, patients with acute limb ischemia, patients with critical limb ischemia, and rest pain and gangrene who are at risk of limb loss. The differential diagnosis of peripheral artery disease is quite broad. As I mentioned, the most common cause of stenotic lesions in the aorta or in the limb arteries is, of course, atherosclerosis. But one can also encounter vasculitis, primarily giant cell or Takayasu arteritis, which involves the medium-sized arteries. Fibromuscular dysplasia, most commonly affecting the renal and carotid or vertebral arteries, has been described to involve lower extremity arteries as well, though it is quite rare. Atheroembolic disease, thrombotic disorders, which can lead to acute limb ischemia, trauma, and radiation injury are also encountered not uncommonly in clinical practice. Popliteal artery aneurysm, when it thromboses, can lead to acute limb ischemia with a rather dramatic presentation. Thromboangiitis obliterans in smokers is much less common now, but should be kept in mind when evaluating patients with critical limb ischemia and digital ulceration. Popliteal entrapment in young athletes can manifest with claudication despite the absence of peripheral artery disease in terms of atherosclerosis. Cystic adventitial disease is a rare phenomenon affecting the popliteal artery. Coarctation of the aorta can easily present with lower extremity claudication in the absence of typical atherosclerotic disease. Vascular tumors, pseudoxanthoma elasticum, are some of the rare symptoms, and of course the iliac artery endofibrosis or the iliac syndrome of the cyclist can occur in vigorous cyclists. The prevalence and incidence of peripheral artery disease is often underappreciated. We know from previously published epidemiological studies that peripheral artery disease can be as prevalent as 1 in 3 patients who have atherosclerotic risk factors. The prevalence of peripheral artery disease understandably increases with age as the atherosclerotic risk factors increase. And you can see here that in the Rotterdam study, when PAD was diagnosed by an abnormal ankle brachial index of less than 0.9, in patients who were 80 years or older, the prevalence of PAD was as high as 40%. Clinical presentation of peripheral artery disease varies. Vast majority of patients are asymptomatic. As many as half of patients with PAD do not exhibit any symptoms, be it because of relative immobility or lack of exercise and exertion, or because of rather mild disease. Intermittent claudication can be seen in 15% of patients with peripheral artery disease. Critical limb ischemia, the most dramatic and critical stage of peripheral artery disease, is fortunately seen in only 1 to 2% of all patients affected with this process. In about a third of these patients, peripheral artery disease can manifest with symptoms which are difficult to characterize and are atypical. Nevertheless, the symptoms lead to significant functional limitation and require more advanced diagnostic modalities and more thorough investigation to tie them to peripheral artery disease. The most common symptom of peripheral artery disease is, of course, intermittent claudication, which is characterized by exertional aching pain, sometimes described as cramping, tightness, or fatigue in the muscle bed affected by the arterial stenosis. Most commonly, this is discomfort which involves the calf muscle, the primary muscle group involved in walking. But depending on the level of disease, it can occur in other muscle groups such as buttocks, hips, and even thighs. It is important to note that peripheral artery disease should not involve joints, and joint discomfort is not a manifestation of peripheral artery disease. The symptoms should be provoked by exertion and should be reproducible from one day to the other on similar terrain and with similar degree of exertion. Another important hallmark of intermittent claudication is the fact that the discomfort should resolve completely within 2 to 5 minutes of rest, only to be reproduced by exertion again. The pathophysiology of intermittent claudication is certainly complex, and it involves metabolic abnormalities related to the reduction in blood flow and oxygen delivery because of the stenosis in the arterial supply. There is evidence that decrease in these metabolic, that the decrease in the ability to deliver oxygen results in an up to 50% reduction in muscle mass and affects the mitochondrial energy processing with demyelination of nerve fibers as well. When evaluating a patient with peripheral artery disease, it is important to consider other causes of leg pain, many of them, of course, increasing in prevalence in elderly population who is also affected by peripheral artery disease. And so one should keep in mind the possibility of spinal stenosis, peripheral neuropathy, osteoarthritis, as well as venous claudication related to reduction in venous return because of venous reflux or underlying venous obstruction. There's also the possibility of chronic compartment syndrome, muscle spasms, effect of statin therapy causing joint and muscle discomfort. All of these can mimic or symptoms of peripheral artery disease unless careful history is taken. After intermittent claudication, it is critical limb ischemia, which, despite the fact that it is much less common, is something vascular practitioners are most concerned with because it is vascular urgency with a high risk of limb loss in the absence of appropriate revascularization. Critical limb ischemia, as seen in these photographs, is easily defined by presence of non-healing ulcer, gangrene, and ischemic rest pain because of multi-level critical arterial malperfusion. The more precise definition of critical limb ischemia can be seen in these societal guidelines. It is best described as ischemic rest pain or tissue loss, non-healing wounds, which are associated with significantly diminished perfusion of the foot and toe as determined by TCPO2 or ankle brachial indices. Evaluation of patients with peripheral artery disease should, of course, start with careful history taking and assessment of the symptoms. After that, vascular examination can yield a lot of insight into the severity and level of arterial disease, measuring blood pressure in both arms to exclude the underlying subclavian artery stenosis, careful cardiac examination and palpation of both the abdomen and popliteal fossa looking for potential aneurysmal disease is still an important part of the exam, despite the ever-increasing access to imaging modalities. Auscultation for vascular bruits, examination of feet and toes, appreciation of all distal pulses is a very important part of a basic cardiovascular exam. Beyond that, the most important test to assess the presence of peripheral artery disease and severity of peripheral artery disease is, of course, the ankle brachial index measurement. A more advanced and detailed test would be the segmental pressure and pulse volume recording exam, which can also be followed with an exercise ABI, where we can assess the resting ankle brachial index and exercise-induced drop in arterial perfusion should there be a stenosis present, which can then lead to a decrease in ABI immediately after exercise is terminated. The ankle brachial index is obtained by measuring the pressure in the brachial artery as well as in the posterior tibial and dorsalis pedis artery using a handheld Doppler instrument. We then take the highest of the two arm pressures and the highest pressure in each ankle and determine the ratio between the ankle and the brachial pressure, thus obtaining the ankle brachial index for the right and left lower extremity. This should, of course, be obtained after an appropriate rest is allowed in a supine position. The normal ankle brachial index is described as a ratio of 0.9 to 1.3. Peripheral artery disease is considered to be present when ankle brachial index is below 0.9. A moderately abnormal ankle brachial index is between 0.9 and 0.6, and severely abnormal ABI is ABI below 0.5, with the likelihood of rest pain, ulceration, and critical limb ischemia increasing when the ABI is 0.4. In some patients, either those with extensive arterial calcification due to, for example, end-stage renal disease, or those with large size limbs, sometimes the pressure in the ankle cannot be obtained because of a non-compressible Doppler signal. Those patients will have an ABI of greater than 1.3, and there is a signal that those patients also have a higher risk of arterial, vascular, and cardiovascular events associated with the arterial calcification. Segmental Doppler pressure and pulse volume recording is a more detailed way of assessing the perfusion of the lower limb. We measure pressure at several levels in the lower extremity, in the upper thigh, lower thigh, upper calf, lower calf, and also at the metatarsal level. In addition, pressure can be obtained in the great toe, and often this allows us to bypass the non-compressibility artifact, and normal toe brachial pressure is considered to be 0.7 or greater. In addition, the pulse volume recording also allows us to get a more graphic depiction of the arterial perfusion. These pressure cuffs allow a measurement of the change in volume in the leg at each level, which is caused by increase associated with every systole. And so that can be translated into a graphic form not dissimilar from depiction of an arterial waveform. So, interpreting this study, we would start with making sure that the blood pressure is equal in both arms. And you can see here that the measurement of ankle brachial indices allowed us to identify a hemodynamically significant gradient in the right upper extremity of 21 millimeters of mercury, which would suggest the presence of either a right subclavian artery stenosis and or innominate artery stenosis. Looking then down each leg, we assess the pulse volume recording and look for blunting in the waveform, which is not present here. We then make sure that there is no evidence of a hemodynamically significant gradient, which is described as a pressure drop of 20 millimeters of mercury between two levels. We do not compare pressure from, for example, upper thigh to the lower calf, but only in the adjacent levels. And so there is no gradient across the thigh, but there is a gradient of 20 millimeters or more in the distal superficial femoral and or popliteal artery. The ankle brachial index is normal at 1.07. It's possible that the pressure obtained in the thigh here is somewhat artificially elevated because of size or arterial calcification. Nevertheless, the presence of a normal ABI and normal pulse volume recording here suggests overall that the limb perfusion here is quite normal or near to normal. The situation is different in the left leg. There is a marked blunting of the pulse volume recording, which suggests the presence of a stenosis upstream to where this recording is obtained in the upper thigh. More importantly, the pressure obtained in the upper thigh has a 78 millimeter gradient compared to the higher of the brachial pressures. And this is consistent with an iliac or proximal femoral artery stenosis. We know the aorta is not involved because the pressure is normal on the contralateral side. There is thereafter no additional significant gradient between the segments, and so it appears that the disease here is isolated to the iliofemoral segment. In patients who may have relatively normal resting ankle brachial indices and who yet have convincing exertional symptoms, exercise testing can be a good way of quantifying the severity of the suspected peripheral artery disease, and of course also qualifying the symptoms. And so in this test we measured the resting pressures and obtained a resting right and left ankle brachial index. And then patient exercises until symptoms occur or the protocol is completed. And immediately, within 1 minute of cessation of exercise, the pressures are again remeasured at 1 minute. And we would anticipate that both the brachial pressure in blue here, as well as the left and right ankle pressure, should increase with exercise, maintaining the same ankle brachial index. And as you can see here, in the left leg, the ABI remains essentially normal and remains so throughout the rest and recovery. However, the right ankle pressure drops precipitously, and the ankle brachial index measured immediately after exercise is 0.3 compared to the resting value of 0.94. Any drop of 20% or more from the resting ABI is consistent with a hemodynamically significant disease. This scenario is commonly encountered in patients with iliac artery disease who may have a moderate or even severe disease without having an abnormal resting ABI. It, however, invariably becomes unmasked during exercise. Additional imaging and diagnostic tests are listed here: duplex ultrasonography, MRA, computed tomographic angiography are the three non-invasive modalities, and of course conventional contrast angiography is still available, though it is rarely used for diagnostic purposes alone, usually when an intervention is planned or when it's performed for the purpose of surgical bypass graft surgery planning. Arterial duplex ultrasound allows us to both locate the stenosis along the limb. It allows us to assess the degree of the stenosis, assess for collateral circulation. It is a very accurate way of measuring the degree of stenosis by comparing the peak systolic velocity prior to the stenosis and at the site of the stenosis, and any ratio exceeding 2.5 is representative of a 50% stenosis or greater. A threefold increase in peak systolic velocity represents a 50 to 75% stenosis, and a fourfold increase is representative of a greater than 75% stenosis. Duplex ultrasound is frequently used for surveillance after bypass graft surgery or after endovascular interventions. Magnetic resonance angiography allows us to obtain an excellent definition of the arterial anatomy. It does not use radiation, and the contrast is less nephrotoxic than the iodinated contrast. There is, of course, the concern about the nephrogenic systemic fibrosis, and patients with low glomerular filtration rate may not be good candidates for this imaging modality. The other thing to keep in mind is that any metallic object in the imaging field, be it a stent or a hip prosthesis, for example, may show as a void artifact and not allow assessment of the artery in that location. CT angiography is a well-established modality, which is also very accurate and reproducible. It has the disadvantages of requiring contrast and radiation. And another pitfall here may be the difficulty interpreting the vessel patency or degree of stenosis in heavily calcified vessels where the calcium and contrast are difficult to differentiate. Moving on to here in this comparison of the SF-36 physical function scores, where patients with intermittent claudication range somewhere between patients with significant COPD and patients with the New York Heart Association 3 congestive heart failure. The natural history of peripheral artery disease is very important to keep in mind when we consider therapy for peripheral artery disease. It is important to note that most of the morbidity and mortality among patients with peripheral artery disease is related to cardiac and cerebrovascular events, not to the limb morbidity. And so patients with PAD are at a much higher risk of suffering morbidity and mortality related to stroke or myocardial infarction. Most commonly, patients with intermittent claudication continue to claudicate at a stable level. 10 to 20% of them progress to worsening symptoms, but only 1 to 2% of patients with peripheral artery disease progress to limb-threatening critical limb ischemia, where limb loss and amputation are a real danger. We know that the mortality from cardiovascular causes increases as the ankle brachial index decreases. This is somewhat logical, as a lower ABI likely represents a heavier burden of atherosclerosis. It is also important to note that a supraphysiologic ankle brachial index related to arterial calcification also carries a higher risk of cardiovascular events. Prognosis of the most severely affected patients with PAD, that is those with critical limb ischemia, is quite dire. Patients who develop critical limb ischemia have a very high risk of amputation and need for revascularization, and very few of them improve with medical treatment alone. The 12-month survival is significantly limited. A quarter of these patients die. 20% of them continue to be affected by critical limb ischemia with significant associated morbidity and impact on quality of life. And only a quarter of them are alive either after revascularization or amputation with no residual symptoms. In 30% of them, symptoms can resolve without amputation, but this invariably requires surgical or endovascular revascularization. And so when we move forward towards treatment goals for patients with peripheral artery disease, we do have to consider what exactly we are trying to address and which aspect of peripheral artery disease we are going to treat. And though in patients who do not have symptoms of peripheral artery disease, we focus on reduction of cardiac and cerebrovascular mortality, and we focus on prevention of progression of atherosclerosis to the point where they would become symptomatic. In patients who have symptomatic peripheral artery disease, those who have claudication, for example, we aim to improve functional status by improving symptoms, improving quality of life, and allowing them to regain some of the functional status and ability to walk and exercise. And finally, in patients who have critical limb ischemia, all efforts are geared toward preserving the limb and avoiding the amputation. Of course, there is a significant overlap in these treatment goals, and every patient who is symptomatic or who has critical limb ischemia will, of course, be treated with the same measures we would employ in patients who are asymptomatic and in whom therapy is directed to prevent cardiac and cerebrovascular events. The most commonly recognized factors for peripheral artery disease and atherosclerosis, and those which form the foundation of PAD therapy, are, of course, smoking, diabetes, hypertension, hypercholesterolemia. It turns out that elevated homocysteine is no longer considered to be a risk factor for peripheral artery disease. It's clear that smoking cessation plays a critical role in improving survival of patients with peripheral artery disease. This is old data from Australia, which shows that tobacco abstinence or smoking cessation significantly improves cumulative survival compared to patients who continue to smoke. It is therefore never too late to stop smoking. It's clear that diabetes increases the risk of peripheral artery disease, and PAD is generally believed to be more common in diabetic than non-diabetic patients. But the data from prospective studies evaluating it is not as robust as one would expect. It appears that tight glycemic control is not associated with a decrease in PAD symptoms or reduction in limb outcomes, other than a reduction of the risk for critical limb ischemia. And so some of the basic interventions, pharmacotherapeutic interventions, which we have employed for quite some time, stem from studies and randomized controlled trials, which are now well established and go back for a better part of the past 18 years. Aspirin, clopidogrel, ACE inhibitors, blood pressure lowering, and statin therapy with LDL lowering have all been well established to be effective in managing patients with peripheral artery disease and reducing both the limb outcomes as well as cardiac and cerebrovascular outcomes. It is clear that patients with peripheral artery disease and no other cardiovascular disease, no symptoms of coronary or carotid artery disease, have a 65% lower all-cause mortality when multiple of these preventive therapies are used. Despite this, data from the ENHANCE study has shown that the use of risk factor modifying therapies in patients with PID has surprisingly low penetrance, as you can see in this slide. It is clear that adherence to the guideline recommended medical therapies improves outcomes in PID, and this has been shown well as recently as 2014. On the red curve, you have patients who are adherent to fewer than 4 guideline therapies, whereas in blue we have patients who are on 4 guideline therapies. Major adverse cardiovascular events are much lower and much less likely to occur when patients use the maximum guideline therapies. This is also true for major adverse limb events such as revascularization or amputation or death, as well as death from all causes. This data for supporting use of these individual therapies comes from numerous randomized controlled studies. To name just a few, heart protection study, for example, assessed the efficacy of cholesterol lowering with simvastatin in over 20,000 of high-risk individuals, those with multiple atherosclerotic risk factors. You can see that in patients who have no prior cardiac or cerebrovascular disease, but who have peripheral artery disease, the overall reduction in major cardiac and cerebrovascular events has been statistically significant, reaching 24% risk reduction. Supporting this notion that the lower the cholesterol, the better these patients, the better off these patients are, is the recent data using the PCSK9 agents such as evolocumab. In this recently published study from 2018, you can see that patients with peripheral artery disease, but with no prior history of coronary artery disease or carotid artery disease, have a dramatic reduction in the risk of adverse limb events when their LDL is maximally reduced with PCSK9 agents. In the HOPE trial, patients with peripheral artery disease were evaluated by being randomized to either placebo or ACE inhibitor ramipril. And this trial from 18 years ago clearly stated that ACE inhibitors are beneficial in patients with peripheral artery disease and effective in reducing the composite outcome of cardiovascular events and death. And this has led to the acceptance that ACE inhibitors are oftentimes the preferred agents used for blood pressure lowering in patients with peripheral artery disease. The role of aspirin in managing patients with peripheral artery disease has for a long time been accepted. And every patient with an abnormal ABI, symptomatic or asymptomatic peripheral artery disease, was certainly treated with antiplatelet agent. This data came from the antithrombotic trialist collaboration going back 16 years ago now, where multiple meta-analyses have shown the benefit of aspirin in patients who have intermittent claudication, though the benefit here was less robust. Patients who have had peripheral interventions, and patients all high-risk patients who are either symptomatic or who have had prior revascularization. This came into question a little later when additional meta-analyses by Berger in 2009 looking at patients with peripheral artery disease who do not have any coronary or cerebrovascular disease, but who have a symptomatic peripheral artery disease. This meta-analysis shown that the benefit of aspirin has not been as robust or as significant as shown in the older meta-analyses, and this certainly brought into question the role of antiplatelet therapy in patients who have peripheral artery disease but do not have established coronary or cerebrovascular disease. This has led to additional studies in the Folk study from 2010. Aspirin was used for managing patients who have asymptomatic peripheral artery disease. This was in a study where patients were invited to undergo screening ankle brachial index testing, and patients who had an abnormal ABI were then randomized to aspirin or placebo only, and followed subsequently monitoring for major adverse cardiovascular events, only to show that there was no significant difference in the incidence of these events in these patients, whether they were taking aspirin or placebo. Now, one of the major criticisms of this study is that these patients had a nearly normal ankle brachial index, keeping in mind that the abnormal value is 0.9. The mean value here was 0.86 in the aspirin group and 0.86 in the placebo group, with a standard deviation suggesting that these were all patients with nearly normal ankle brachial indices who had a very mild, if any, peripheral artery disease. And so this was not a group of patients who had a significant lower extremity atherosclerosis, and maybe these numbers and this data cannot be applied to patients with more profound decrement in ABI. POPAD study investigated the role of aspirin in patients who have diabetes and also have abnormal ABI without any symptoms, so asymptomatic peripheral artery disease. And these patients were randomized to arms with aspirin and an antioxidant, aspirin alone, antioxidant alone, or double placebo. As you can see on the right side of the screen, taking together patients who were on aspirin and who did not take aspirin, there was no significant difference in the composite endpoint of death from coronary heart disease or stroke, non-fatal myocardial infarction or stroke, or limb amputation or critical limb ischemia. Similarly, there was no difference in the mortality rate from coronary artery disease or cerebrovascular disease. However, it is important to note that these patients who were supposed to have asymptomatic peripheral artery disease really had normal ankle brachial index, thus questioning whether this population did indeed have peripheral artery disease. Interestingly, in this group of patients, treatment with aspirin seemed to reduce the risk of stroke and reduce the progression of peripheral artery disease to the point of developing claudication. Now, the Capri study also investigated, now almost over 20 years ago, the role of clopidogrel or Plavix in management of patients with peripheral artery disease, showing that it was efficacious in patients with peripheral artery disease in terms of reducing major adverse cardiovascular events. Putting Plavix on the map as an alternative to aspirin and possibly a superior agent, despite the increased risk of bleeding. The Charisma trial, published a decade later, investigated the use of dual antiplatelet therapy, that is aspirin and clopidogrel, in patients who were at an increased risk of systemic atherosclerosis, but who have not suffered myocardial infarction, stroke, or symptoms of or need for revascularization of lower extremities, for example. And so these patients were randomized to receive dual antiplatelet therapy or monotherapy with aspirin. And famously, this study showed no difference in reduction of the primary outcome of myocardial infarction, stroke, or cardiovascular death in these patients. However, subsequent post hoc analysis looking at patients with peripheral artery disease, there was a signal that dual antiplatelet therapy did play a role in reducing the risk of myocardial infarction and hospitalization for treatment of vascular events. Nevertheless, overall, this study put an end to the, at that time, common practice of using dual antiplatelet therapy in patients with symptomatic or asymptomatic peripheral artery disease. The advent of novel antithrombotic and antiplatelet agents has led to several studies investigating the role of these agents in patients with peripheral artery disease. Vorapaxar, for example, an inhibitor of the protease activating receptor 1 and an antiplatelet agent by the virtue of reducing thrombin mediated platelet activation, was investigated in the TIMI-50 group, used for secondary prevention of cardiovascular events in over 26,000 patients who recently suffered myocardial infarction, stroke, or who had symptomatic peripheral artery disease. And these patients were randomized to vorapaxar or a placebo in addition to another antiplatelet agent, be it aspirin or clopidogrel. It turned out that the addition of vorapaxar did not result in a significant reduction in the risk of recurrent cardiovascular events, but was associated with both a GASTO and TIMI bleeding rates that were much higher than in the placebo group. However, patients with peripheral artery disease did experience a reduction in limb-related events, and so there was a reduction in the risk of hospitalization for acute limb ischemia in patients with peripheral artery disease, and reduction in the need for repeat revascularization. This led to use of this agent for a period of time in high-risk vascular patients, but its use has been mitigated by the increased bleeding risk. More recently, earlier this year, the COMPASS trial was published, and in this study, rivaroxaban was tested in patients with stable peripheral or carotid artery disease. 3 arms were investigated: rivaroxaban alone at 5 milligrams twice a day, aspirin alone, as well as rivaroxaban, as well as a combination of aspirin, 100 milligrams, with rivaroxaban at a lower dose of 2.5 milligrams twice a day. The low-dose rivaroxaban and aspirin group experienced a reduction in both the major adverse cardiac events and the major adverse limb events when compared to patients treated with aspirin alone. There was an uptick in major bleeding, which was not fatal or critical. The higher dose rivaroxaban alone group did not experience a reduction in the cardiovascular events, although there was a reduction in the limb events compared to the aspirin arm. However, this came at a cost of much higher risk of bleeding. And so it seems that in patients with peripheral artery disease, the combination of aspirin and low-dose rivaroxaban at 2.5 milligrams twice a day may be efficacious. And so using some of these studies to very rigorously apply that data to patients with peripheral artery disease, we can use the algorithm described recently by Bill Hyatt and Hess and published earlier this year in JAMA. Now, this is a strictly evidence-based approach and not necessarily reflected in the current guidelines, but it's rational to approach patients with peripheral artery disease and divide them into either asymptomatic or symptomatic peripheral artery disease, and at the same time categorize them based on the presence or absence of cardiac or cerebrovascular disease. And so patients who are asymptomatic as far as peripheral artery disease is concerned, that is no claudication and no critical limb ischemia despite an abnormal ABI, and those who do not have any underlying coronary or cerebrovascular disease, based on the FOX data I described earlier, they may not qualify for any antithrombotic therapy. It is important to keep in mind, though, as I pointed out, these patients studied in the trial had an essentially normal ankle brachial index, and therefore may not have represented well a group that we would describe as asymptomatic PAD, and that is a significant criticism of that paper and the consideration of not using antiplatelet therapy in patients who do have an abnormal ankle brachial index. However, even if asymptomatic PAD is present, if the patients are asymptomatic as far as peripheral artery disease is concerned, the presence of any additional coronary or cerebrovascular disease manifestation would, of course, support the use of antiplatelet agents, be it aspirin, clopidogrel, or one of the newer antiplatelet agents. The data from additional studies would suggest that patients who have symptomatic PAD, even in the absence of coronary or cerebrovascular symptoms, do qualify for antithrombotic therapy with clopidogrel or aspirin or some of the newer agents. And then patients with symptoms of both peripheral and cerebrovascular and coronary artery disease, of course, would qualify for antiplatelet therapy. One could consider Vorapaxar in high-risk vascular patients. This analysis, of course, predates the publication or approval of the rivaroxaban 2.5 milligram twice a day dosing, which is not reflected in this algorithm. Moving forward to the current American Heart Association and the American College of Cardiology guidelines for management of patients with lower extremity peripheral artery disease, published a year ago in 2017. It is important to note that antiplatelet therapy with aspirin alone or clopidogrel alone is recommended in all patients with symptomatic or asymptomatic peripheral artery disease, primarily to reduce the risk of myocardial infarction, stroke, or death in patients with, and that's in patients who are certainly symptomatic. In patients who are asymptomatic and who have peripheral artery disease, the guidelines also support the use of antiplatelet therapy, though this recommendation is not as robust. The use of Vorapaxar is cautioned against, as the overall benefit is uncertain and mitigated by the bleeding complications. The guidelines strongly urge treatment with statins and any therapies designed to lower the LDL based on the trials we just discussed. Blood pressure control is paramount, and the use of ACE inhibitors is recommended, recognizing well that any agent that reduces blood pressure is, of course, adequate for this purpose. Systemic anticoagulation with warfarin and other agents is not supported. This again is a guideline that was published before the publication of the COMPASS trial, which investigated the role of rivaroxaban. Furthermore, the guidelines urge discussion and consideration of smoking cessation, as well as management of diabetes mellitus with glycemic control, which is primarily beneficial in patients with critical limb ischemia, aimed to reduce limb-related outcomes rather than cardiac or cerebrovascular morbidity and mortality. Now, when it comes to patients who are actually symptomatic, in addition to pharmacotherapy, the goals of managing these patients include maintenance or improvement of the functional capacity, a reduction in claudication symptoms. And for this, of course, the mainstay of therapy is the supervised exercise, pharmacotherapy with cilostazol, for example, and of course, revascularization. Exercise therapy for patients with intermittent claudication has been used and recognized for a long time. It is, of course, therapy that requires commitment in time and energy, and until very recently, it was not part of reimbursable rehabilitation program. Cilostazol is effective in reducing symptoms of claudication and improving walking distance, of course, only in combination with concomitant exercise therapy. And you can see in this classic trial from 20 years ago, cilostazol at 100 milligrams twice a day can significantly increase and double claudication-free walking distance. Pentoxifylline has been long discredited as no better than placebo. Simvastatin and atorvastatin have been shown to improve walking distance in patients with claudication, as described in these two smaller trials. Similar results have been suggested with ramipril, though this study was small in number and has not been reproduced. Now, in patients who continue to have lifestyle-limiting symptoms despite maximal medical therapy, which includes, of course, exercise therapy, revascularization may be an option and should be considered. Clearly, in patients with critical limb ischemia and those with high risk of limb loss, revascularization is a matter of urgency. Today, more and more commonly, endovascular revascularization therapies are the first-line approach, with ever-increasing armamentarium of stents, drug-eluting stents, atherectomy devices, and drug-eluting balloons. Surgical bypass grafting is still an option in patients who, for one reason or another, are not suitable candidates for endovascular approach, or in whom endovascular therapy, particularly with long segment occlusions, is not feasible. The role of exercise therapy has long been juxtaposed to revascularization. And the most recent, one of the more recent trials investigating or comparing the role of supervised exercise as compared to revascularization was, of course, the CLEVER trial published in 2015, where patients were randomized to either medical therapy alone, exercise therapy, or revascularization, and it in the course of 6 to 18 months of follow-up, it became clear that patients who underwent revascularization or exercise therapy experienced a significant increase in walking distance and reduction in symptoms of peripheral artery disease. The ARRACE trial looked at it from a different angle and combined supervised exercise therapy with revascularization and compared it to supervised exercise therapy alone, following the logic that combining both revascularization and exercise therapy, in addition to medical therapy, of course, has to be beneficial and superior to any of these therapies alone. And indeed, in the course of 12 months follow-up, it was clear that a combination of both approaches was superior in terms of increasing pain-free walking distance compared to exercise alone. This was also a topic investigated in the MIMIC trial, and subsequent meta-analysis combining these trials clearly showed that a combination of endovascular therapy, revascularization, and supervised exercise therapy is superior to exercise therapy alone in terms of improving quality of life and walking distance in patients with peripheral artery disease who are symptomatic. And so it's clear and reflected in these guidelines that as a first step, in patients with claudication, an exercise program is recommended, and if not satisfactory in terms of its outcome, combining it with revascularization, endovascular revascularization, is of course the preferred strategy. Of course, the supervised exercise program has to be quite rigorous, including 30 to 45-minute sessions that are performed at least 3 times a week for a minimum of 12 weeks, and who are then followed up with a self-guided exercise regimen. In terms of pharmacotherapy for patients with claudication, cilostazol is the mainstay of the guideline-recommended therapy, and chelation therapies and pentoxifylline have been discredited. And again, the revascularization is a reasonable treatment option for patients who have lifestyle-limiting claudication despite guideline-directed medical therapy, which includes exercise therapy. So the take-home messages from this presentation is that the prevalence of peripheral artery disease increases with age, and among patients who have cardiovascular risk factors, who are smokers, who have diabetes, dyslipidemia, and hypertension. Patients with peripheral artery disease have a high risk for future cardiovascular events, whether they are symptomatic or asymptomatic as far as the PAD is concerned. Risk factor modification, antiplatelet therapy are the cornerstones of therapy for patients with peripheral artery disease, both in order to reduce the cardiovascular risk and to reduce the limb-related risk. Exercise therapy and cilostazol are the first-line approach to intermittent claudication, which is then supplemented with endovascular therapy. In patients with critical limb ischemia, revascularization is a matter of relative urgency in order to preserve limb and avoid amputation. Moving on to a couple of questions relating to this discussion. We have a 61-year-old man who is seeing a physician for a complete history and examination. He feels well and has absolutely no complaints, but as you can see, he continues to smoke. He has mild hypertension, whose exam is notable for diminished pulses in the left foot. And the question here is, in addition to evaluating his renal function, lipid levels, glucose levels, which other tests would be reasonable to obtain in order to assess his overall cardiovascular risk? Would it be A, the ankle brachial index, B, pulse volume recording, C, duplex ultrasound of the leg arteries, or D, CT angiogram of the aorta and the lower extremity arteries? And of course, the answer is the ankle brachial index, which would presumably diagnose the presence of peripheral artery disease. And as we know from the earlier slides, the presence of PAD, abnormal ankle brachial index, increases the risk of subsequent cardiovascular events. Question number 2, a 64-year-old man has been troubled by left calf discomfort for the past few months, and the discomfort occurs every time he walks a distance of more than 3 city blocks. The blood pressure on physical exam is equal in both arms. The femoral pulses are absent, and the right pedal pulses are not palpable, but the left ankle pulses are not palpable, and the pressures in the left ankle are abnormal, as you can see in this clinical vignette. Which of the following treatments should be considered to improve walking distance? Clopidogrel, supervised walking program, iliac artery bypass graft, or evaluation for left iliac artery stent or angioplasty. And of course, the guideline recommended approach here would be the initiation of medical therapy, but from the options available here, supervised walking distance, in addition to cilostazol, would be the best first option. Question number 3 refers to a patient who complains of right foot pain for the past 2 weeks, which is present at night and at rest, forcing her to sleep with the leg in the dependent position in a chair. On exam, the foot is cool with absent pulses and evidence of an ulcer at the toe. The ankle brachial index is severely diminished at 0.4, and the magnetic resonance angiography you obtained showed occlusion of the right superficial femoral artery. Which of these therapies should be considered first? Initiation of heparin and then warfarin, initiation of aspirin and cilostazol, right femoral popliteal artery bypass graft, or administration of endothelial progenitor cells. And as we discussed previously, the presence of critical limb ischemia, as described in this clinical vignette, warrants consideration of revascularization with a goal of limb salvage.